Well, thank you so much thank you so much to the QIC for arranging this course and for inviting us. It's Ahmed Salam here from the University of Arkansas, USA, and it's my pleasure to moderate this session, which is a uveitis instruction course. We'll try to cover most of the important parts, which is difficult, as we were saying. Our first session will be on anterior uveitis, and we'll start with Dr. Dina Badar from Cairo, Egypt. Dina, thank you so much for joining us.
Thank you, Dr. Salam, for your kind invitation, and thank you for inviting me to this prestigious meeting. So I will talk today, I will introduce everybody to uveitis through the anterior uveitis, which is the more simple, basic kind of uveitis. I'm Dina Badar. I'm from Cairo. I practice in Research Institute of Ophthalmology in Cairo and Al Watani Eye Hospital. So with anterior uveitis, we have to look at the age of the onset, the laterality, whether it's granulomatous or non-granulomatous. We have to decide whether it's acute, recurrent, or chronic. And this is key because it will shift our understanding of what's happening in the eye and also decide on the course of treatment. Also, a determining factor is IOP and the complications that the patient present with. I think what I'm trying to say through my talk today is that anterior uveitis is not only about eye drops. So let's look at clinical scenarios. Okay, so scenario number one, this is a 34-year-old female. She's a physician. She has had an onset 18 months prior to presenting to me of shimmering lights in the left eye, and she was diagnosed as migraine. She had only a bit of AC cell between half plus and 1 plus, and she's been on topical Pret-Forte. This is a patient that has not been well examined. The periphery has not been well examined. She does have multifocal choroiditis, and because of the posterior synechiae, the posterior segment was not well examined. So this is the first clinical scenario. The second one is a 63-year-old female patient with history of cataract surgery in the left eye. She had chronic iritis before her surgery, and the vision was poor. As you can all appreciate, there's cystoid macular edema on FE and not a lot of haze. So my first take-home message is uveitis assessment, even if it's only anterior uveitis, it is never complete without dilated fundus examination. The second scenario is an adult who walks into the clinic with chronic uveitis. They have been on topical treatment. They have variable posterior synechiae, variable amount of cataract. This is a patient who was not worked up properly. When we did the tuberculin skin test looking for TB, it turned out to be positive. So this is a patient with an actual chronic disease, a systemic disease, and not only anterior uveitis. So with chronic anterior uveitis, please search for an associated systemic disease. The third scenario is a 32-year-old male who has had chronic anterior uveitis in one eye. He had those small granulomatous KPs. His course waxes and wanes. He doesn't keep to the doctor appointments. And in the office, when we asked about any rashes, skin diseases, or arthritis, he exposed his elbows and we saw this psoriatic rash. Also, very commonly, when you ask patients about dandruff and when you look at the scalp, we can find such patches on the scalp. Now, this in fact is psoriasis associated anterior uveitis. Another scenario is a 53-year-old male with chronic anterior uveitis, not a lot of AC cell, but a very, very pinpoint pupil. Nothing is happening in the back of the eye. But again, when we asked about arthritis, we noticed that he has this claw hand deformity. This is in fact leprosy. And leprosy is known to cause anterior uveitis because it has an affinity for the cooler cornea rather than the warmer posterior segment. So the take-home message on those patients is an associated pathology can be picked up at the office. Look at the patient, take history, and examine any rash or skin disease or even arthralgia that they might have. Scenario number 4, which I think everybody has been exposed to, is an adult who walks into clinic with recurrent redness affecting the same eye. Usually there is a high IOP and there could be those skin lesions, whether they're active or they're going away and you can only see the scars. This is in fact herpetic uveitis. When you look at the eye, there's a variable amount of transillumination of the iris, and sometimes uh, if you examine close enough the cornea, you can find endotheliitis. So this is herpetic uveitis, which could be caused by either a herpes zoster or herpes simplex. So zoster is known to cause this classic rash that we all know, and herpes simplex, you can elicit a history of a corneal ulcer or recurrent redness in this eye with high IOP. So look out for viral etiology. And since we are on the talk of the hour, COVID-19, here's a 42-year-old female. She had had suspected SARS-CoV-2 infection 3 weeks prior to presenting to us. She had been on prophylactic antibiotic that we didn't know the name of when we first saw her. 10 days later, she suffered severe pain and photophobia in both eyes, and she was referred to the uveitis clinic. By examination, we could only see a bit of AC pigmented cells. And as you can see, there's transillumination defects in the mid-iris and heavily pigmented angle. Now, this is something that is up and coming, is bilateral acute iris transillumination, or BATE syndrome. It's a spectrum. There's BATE, the transillumination, and then there's BADI, which is the acute depigmentation of the iris. This is a patient who was referred to me because she noticed after taking this antibiotics, which is a levofloxacin, as you can see, she noticed that her iris has changed color. So it's kind of a new entity. It's drug toxicity related to systemic fluoroquinolones more than topical. Actually, it usually happens 10 days after administration, and I've been seeing a similar pattern after SARS-CoV infection. This is actually a patient that I've been following up. He's a 42-year-old male. He was diagnosed with HLEB27 uveitis. He's positive for HLEB27, and in between the attacks, his eyes are normally quiescent. Now, he presented 2 weeks after PCR positive COVID with this transillumination, and this is something that I would like to hear the opinion of the panelists on. Do you see this after SARS-CoV-2 infections? So certain drugs and obviously COVID infections are associated with anterior uveitis. Look out for the anterior chamber cells, whether they're pigmented or not, whether it's activity or pigment dispersion. Now, this is the more common scenario. You find a patient walking in with an acute red eye. This might not be his first attack, alternating. You can ask for low back pain. You find positive low back pain or cervical pain, fibrinous AC reaction, marked photophobia, and a lot of AC cell. Now, this is HLA-B27 related anterior uveitis. Although it's normally anterior and it's with treatment, it takes about 6 to 8 weeks to go away. I always get the gene and I get imaging MRI for the sacroiliacs and the cervical spine, and then I refer to rheumatologist. Another typical scenario is a kid accidentally discovered poor vision in a white eye, big history of arthropathy. We see chronic anterior uveitis, a variable degree, posterior synechiae, cataract, band keratopathy, visual debilitation. This is the very sad scenario of GIA. Now, the last take-home message that I have is some conditions are known to cause anterior uveitis, but they require systemic disease-modifying treatment and referral to rheumatology. Last thing I'm going to discuss, which is an honorable mention, of course, immune checkpoint inhibitors. These are drugs that block proteins called checkpoints. Those checkpoints may be the T cells, and when we block T cells, this increases uveitis. They commonly cause anterior uveitis, and they do really well with topical and systemic drugs. My last slide is a cookbook for anybody who is treating anterior uveitis in the community. If it's an adult, that's what I look for. Again, as guided by the history, I get ACE, ALT, Cariat, quantiferon in everybody. Not a lot of syphilis in my part of the world. I get HLA-B27 and calprotectin in stools according to the history. In pediatric age group, I get ANA and beta-2 microglobulin beside everything else. And thank you all for your attention.
Thank you so much. This was a great presentation. Because this is an instruction course, I just want to focus on the basic things if young ophthalmologists are listening to us. So how long do you treat a case of acute anterior uveitis? So you give them topical
That's a very
steroids.
good.
Can you, in short, can you tell us like the regimen?
Okay, so it depends if it's unilateral or bilateral, and it depends if I find something that is
Let's say
underlying.
unilateral acute anterior uveitis and there is nothing revealing by the history.
Okay, so I start depending on the anterior segment inflammation. I give the topical treatment, and I see them in 2 weeks. I start tapering their topical steroids, and if they flare at any point, then I keep them on, say, twice a day, depending really. So the safe amount of prednisone that you could be on is about 2 to 3. This is quite safe in terms of cataract and IOP, and then I bring them in just to
How many
to check.
weeks? How many weeks do you give them? Do you give them like a specific weeks or it varies?
I I'd say I'd start with 2 weeks and bring them in, and then I'd see them every 2 to 3 weeks and
Okay.
taper
All
them
right.
out.
So yeah, just maybe like again, in many people would do like a 6 weeks course, and I think this probably include similar to what you do, like a total of 6 weeks course, and then the message really again is if they flare up more than 3 months, then this is another episode. But if it's less than 3 months and chronic anterior uveitis, and they need more long-term treatment. Okay, my second point is for GIA uveitis, when do you advise the rheumatologist to give them systemic treatment? Would you tolerate like a +1 cells or +half cells?
Yes, with chronic anterior uveitis, we
No,
with
the
1+1.
GIA. No, for
Yeah,
GIA.
in GIA. Okay, so it depends really on the amount of complication that they have, and in the amount of, so if I have to use drops 3 or 4 times a day, and there's high ESR, I leave it to the rheumatologist. Sometimes they start giving them systemic and non-steroidals, rather than systemic steroids or disease modifying drugs, and I find them that they do help with the eye. So basically, if I have to use drops 3 times or 4 times a day, and I'm starting to see an elevation in the IOP or in the cataract, then I would start systemic medication.
Thank you so much. Dr. Pafizi, can we have a quick answer to this? Would you tolerate a +1 or a +half in children with GIA on, let's say, controlled on 2 times a day, or you would refer them for systemic treatment?
That's for me, Ahmed. Is that?
Yes, if
Yes.
we
Okay.
can have a
Yeah.
quick answer before our next break.
Yeah. No. I think the ideal scenario is to really not to have any inflammation. I think that's what you want to achieve. What happens sometimes that is very minimal degree. If you have a 0.5 plus cells and you are controlling it very well, very stable, then you might have to say that you may be able to accept that level for long-term control. Ideally, 0 would be your ideal scenario. That's what you want to achieve, complete remission, complete control. But in practical terms, it's not always achievable. And in some patients, you have to accept that 0.5 plus is something that you may have to live with. But I always get them very quickly to get to see a rheumatologist to start the systemic therapy. I don't leave these kids on topical therapy alone very long at all. I think it's a very short course. If they don't respond well, they go straight to systemic therapy. Very little tolerance for that. Yeah.
Thank you so much. Okay, again, for the sake of time, thank you again so much, Dina, for this excellent presentation. For the sake of time, we'll move to Dr. Adan from Spain. Dr. Adan, thank you so much for joining us today. And if you can please share your screen.
My talk will be about non-infectious posterior uveitis. Non-infectious posterior uveitis can classify in 2 groups. One group is this posterior uveitis associated with systemic disease, and the other is the non-associated with systemic disease, that this group of posterior uveitis are the white dot syndrome. I will focus in my talk in the posterior uveitis, non-infectious posterior uveitis associated with systemic disease. The diagnosis of this type of posterior uveitis is very important because many cases are the uveitis is the first sign of the systemic disease. So the role of the ophthalmologist is very relevant, and is very important the multidisciplinary approach of these patients. The first disease is Behçet disease. Behçet disease is a chronic multi-system and inflammatory disorder. Probably has an immune origin, but many of the patients are young adults, are different countries around the world, but especially in the Mediterranean area that are affected by this disease. In Spain, we see many cases, and all the Mediterranean area. And this is a multi-systemic disease with the eye inflammation is very relevant, and is a very important point is the disease is the clinical diagnosis. So the role of the ophthalmologist is very relevant in this disease. So you have to classify the disease in order of the uveitis symptoms of the patient and uveitis signs of the patients, and also for the presence of the cutaneous and the genital alterations. And there are other signs that there are less frequent, but for the diagnosis for the patient, the role of the ophthalmologist is very important. This is a classic report about the Behçet disease for the group of Turkish group of the İlnur Tukun, and we see in the right that the majority of the patients is a very large patient with Behçet disease. The majority of the patients has oral ulcers, and many patients also that genital ulceration. So the majority of the cases with affectation of the eye has systemic disease in terms of oral ulcers and genital ulceration. The disease can be very, very, very aggressive. These patients, the patient that I show in the slide is a patient with occlusive vasculitis, severe vasculitis that is very important, the treatment of these patients. But in my experience, the majority of the patient has these focal infiltrates, these white patches in the retina. They are in the posterior pole, in the peripheral part of the retina, but they are a sign of also inflammation and probably ischemia also. So there are the vitreous is with cells in the majority of cases in the active part of the disease. The OCT, the structural OCT is also an important tool to diagnose this disease. The inflammation, as you see in the left OCT, is a lot of cells in the vitreous and also a macular edema. And in the right part, probably this is an image with fibrin in the macula that is associated with the hyperacute part of the disease. Other cases with Behçet has more vasculitis. The majority has periphlebitis with these infiltrates also in the retina. The two things: the vitreous cells, infiltrates, and also, as you see in the left part, the periphlebitis. And also there are patients who develop the retinal neovascularization, even with optic nerve neovascles or extra or peripheral neovascles with vitreous hemorrhage. Fluorescein angiography helps to diagnose the patient and to guide about the treatment we have to introduce in the patients. This patient with Behçet disease, as we see in the fluorescein angiography, white field has ischemia in the periphery, in the nasal periphery, but also has macular edema and leakage in the also temporal part of the retina. And these other cases has neovascles and ischemia and inflammation in the peripheral part of the retina in the left part of the slides. The second disease is sarcoidosis. Sarcoidosis is a difficult diagnosis, but the patient with sarcoidosis, many of the patients has, as the patient that I show in the right part of the slide, has a choroidal, extensional choroidal involvement in the macula in that case. The diagnosis confirmed of sarcoidosis is by biopsy, but in many cases, the biopsy is complicated to obtain, and in my experience, it's very important to perform if we suspect sarcoidosis, a chest CT scan that in many cases is suggestive of sarcoidosis. There are different possibilities or different posterior uveitis in cases of sarcoidosis. We can see a macular involvement, macular choroidal involvement. Other possibilities are multifocal choroiditis in the inferior part of the retina. So OCT angiography, especially sweat source OCT angiography, is very demonstrative in terms of the choroidal involvement of these patients, like the patients that I show in the left part of the slides. And in some cases, we can use for the diagnosis, if the patient has vitreal involvement, we can perform vitrectomy. We can also measure the CD4, CD8 ratio in the vitreous fluid, and even also the possibility of granulomas in the vitreous. And the last disease is BKH. BKH is as you know, the OCT changes are very suggestive of the disease with this bacillary detachment, and also the patient has detachment, has also optic nerve involvement and systemic signs. The fluorescein angiography is very typical with these points, and also the leakage and the dye of the pooling in the late part of the angiogram. Many cases also can have inferior exudative retinal detachment, and in the majority of patients has also neurological symptoms, especially headaches, tinnitus, or in many cases then meningismus also is associated with the disease. So the cases, the evolution with the treatment is quite good, and this is a patient treated with intravenous methylprednisolone with a good response. So OCT angiography, structural OCT sweat source is very useful in terms of the measure of choroidal involvement and retinal involvement to follow up with the patients. And in case of the chronic involvement, we can see these nummular lesions. This is a white-field image, very typical with the despigmentation of the fundus of the eye, and this migration of the pigment to the macula. And the last is sympathetic ophthalmia, is similar to BKH, and this is a case that recently we seen in our in our clinic. This has a very similar aspect to the BKH. So in those cases, it's very important the relation with the systemic approach, multidisciplinary approach, and the multimodal approach from the ophthalmologist in order to perform the correct diagnosis. Thank you very much.
Thank you so much, Professor Adan. We have 1 minute for a question. Any questions to Professor Adan from the panel? Okay, Professor Adan, I have a quick question, if I may. So if you see a patient with an undifferentiated posterior uveitis, so it doesn't fit really into one of the easy, well-known disease, how would you treat this patient at the beginning, trying to figure out if it's infectious or non-infectious?
I think it is very important to rule out the causes of the infectious uveitis, because that is the most important point, because the infectious uveitis you have to treat depending on the cause of the infectious agent that caused the uveitis. So that this is for me the most important thing. But the other non-infectious, all the patients has a good response to the steroids, the systemic steroids. So you have to use all the image that you have. It's very important to work with the rheumatologist in order to know if the patient has systemic disease. But I think in the majority of cases with non-infectious disease, the steroids are the first line, and the good response to the steroids is in the majority of these cases.
Well, thank you so much. Okay, our next speaker is Dr. Hassan Al-Dibi from King Khaled Eye Hospital in Saudi Arabia. And Dr. Hassan Al-Dibi is a senior academic consultant and an adjunct professor for vitreoretinal and uveitis. Dr. Didi, please.
Thank you, Dr. Ahmed. And I would like to thank you for giving me this opportunity to participate in this course. And infectious posterior uveitis is one of the most important, entities of uveitis that we need to give an attention when we are seeing a patient with, posterior uveitis or bony uveitis. And usually we ask how to go and to look for the to rule out that, so that clinical features plus investigation might help. Posterior uveitis could be classified in focal retinitis, multifocal retinitis, focal choroiditis, and multifocal choroiditis. And each entity of this having its own causes, but eventually some of them can lead to bony uveitis. So looking for these causes, it's an important to realize it based on the clinical scenario that you have it, and then you can use lab test to rule out. So making things uneasy, we have to go for the most common infectious etiology for posterior and bony uveitis. Upon survey that of uveitis done in our hospital, we found that the uveitis is counting for 20% of our patients. And looking for the causes, we find that the tuberculosis, herpetic uveitis, toxoplasmosis, and acute retinitis are the most common causes. Causes of posterior uveitis include CMV retinitis and toxoplasmosis. Toxoplasmosis is the most common cause of posterior uveitis. And in cases of bony uveitis, we find that the presumed intraocular tuberculosis and acute retinitis are the most common causes of that. So when I'm looking for herpetic retinopathies or infectious, we find that to divide it in normal and immunosuppressive status. If the patient is having, immune competent, we have to think about acute retinal necrosis and non-necrotizing viral retinitis. While in immunocompromised patient, we have the CMV retinitis and PORN in the same time. So this is the entities that need to be given attention when we are looking for patient with possibility of posterior infectious uveitis. Looking for acute retinal necrosis, it is severe sight-threatening disease and diagnostic anterioveitic emergency as the top of them. It is usually unilateral, but involved of the second eye in 70% of the patient. Both six are equally affected, and the two peaks age distribution in 20 and 50, and in the herpes zoster varicella zoster virus in old patient, while herpes simplex 1 and 2 in the young patient. There are a couple of risk factors, including young age, healthy, and neonatal herpes, pre-existing chororetinal scars, and trauma or systemic corticosteroids. Usually the system, like any posterior uveitis, red eye, photophobia, tearing, periorbital pain, and floaters. The signs are cover of anterior vitreitis, typical peripheral retinitis, and occlusive vasculitis, as we see in these pictures. Most of these signs are really diagnostic for the. I will not talk about this, the whole of the signs, but in general, we have to use standard diagnostic criteria by Dr. Henry Rath. Showed that the most important one or more foci of retinal necrosis with discrete border of there. In addition to that, it is circumferentially spread with vitreous, inflammations, and usually having rapid progression of the disease with evidence of occlusive vasculitis. So anterior uveitis is part of the this disease. Vitreitis is a prominent feature of acute retinal necrosis, as we see in these pictures, and usually having moderate or severe and worsen as course of the disease is progressing. Necrotizing retinitis, the main whole signs of the disease, usually having focal, well-demarcated areas of full thickness retina necrosis in the equatorial and pre-equatorial. They have usually sharp demarcation between the whitened involved retina and the normal retina, and usually associated with moderate retinal hemorrhage with rapid progression circumferentially as well as posteriorly. Usually the macula is not involved, but in severe cases might be involved, and usually might having an occlusive retinal detachment or even though optic nerve involvement. This is how to go and assess the severity of the disease, and usually minimal if less than 25% of the retina involved, and severe when there is 50% of the retina were involved. Retinal vasculitis is part of this. It's usually occlusive, and arterioles are enforced more than the veins, as you see in these cases here. Sclerosed blood vessels with active vasculitis. Optic disc involvement is one of the major and indicating poor prognosis of the patient. Diagnostic of the acute it depends on the clinical characteristic, and that could be supported with lab tests like viral PCR, viral culture. It's important to confirm the diagnosis to make the differential of acute from other entities possible, and usually to have to identify the cause so that we can direct our treatment. Complications are a lot, and among of them is that retinal detachment related to the necrotic retina with the retinal holes, and retinal detachment could be occurring 50 to 75% of the patient, and usually in severe form they have a BFR and poor outcome. Other complications include epiretinal membrane, cystoid macular edema, and serous retinal detachment. Differential diagnosis important to make sure about it. Here in these cases, as usually the picture is not clear unless you are familiar with the retinitis that happened in this. So toxoplasmosis, retinochoroiditis is an important. Syphilis, bacterial, fungal retinitis or endophthalmitis. Another non-infectious causes like sarcoidosis, Bahjat disease, or lymphoma. And in other part, we have to put porn, progressive outretinal necrosis, and CMV retinitis in the differential diagnosis. Other entities that born, it's almost similar to the acute retinal necrosis, but this is involved the posterior part of the macula in immunocompromised patient with CD4 count less than 100 cells per microliters. Usually, it's having parafoveal ossification with cherry red spot, as we see in this case, and not contagious with the peripheral retina. Usually, they have an afferent biliary defect and optic nerve involvement in these cases. If the disease quotient usually lead to dense white flakes, cracked mode appearance with atrophic area and holes. CMV retinitis is an important cause of posterior uveitis, and especially in immunocompromised patient, and especially in AIDS patient with CD4 count less than 50 cells per micro. Incidence in individuals with AIDS in the era of hearts decreased to 0.336 per 100 when you compare it by usually bilateral in 52% of the patient, and mild signs of inflammation including fine KBs and AC cells, and with minimal vitilitis as one of the signs that differentiate between acute retinal necrosis and CMV retinitis. This is the pattern of active lesion. Usually you have hemorrhagic, scrambled like eggs with ketchup, and granular and frosted branch, as we see in these cases. The treatment of acute retinal necrosis, usually this is the medication that we have it, acyclovir, valacyclovir, ganciclovir, valganciclovir, and fosicar, and famiciclovir. In particular, it is an emergency situation, and we start with antiviral intravenous acyclovir 10 milligram per kg per day in 3 divided doses for at least 10 to 14 days. The alternative is foscarnet. Intravitreous ganciclovir is an important aids in treatment of these cases with 0.2 to 2 milligram per 0.1 millimeter. Laser treatment in cases as a prophylactic, and vitrectomy for relief the tractions. Porn is considered an emergency, and treatment with combination of intravenous foscarnet and intravenous ganciclovir plus intravitreal gan acyclovir injection. In these cases, we need to have CNS workup as it is could be involved. And this is the medications for CMV retinitis, and ganciclovir intravenous induction with 5 milligram kg twice daily for 14 to 21 days, followed by maintenance regime, and can cause leukopenia. Intravitreal ganciclovir is recommended 1 milligram in 0.1 twice weekly for active disease, and once weekly for maintenance dose. So in summary, for viral retinitis, it is very common in our clinical practice, and necrotizing viral retinitis are sight-threatening disease, diagnostic and therapeutic emergency. Diagnosis for herpetic retinitis is primarily based on the clinical features. Laboratories is helping to confirm the diagnosis, especially PCR. Treatment is complex, and requires careful monitoring to provide the appropriate balance of antiviral medication and corticosteroid. Other causes is toxoplasmosis, and this is related to etiology of Toxoplasma gondii, which is a obligate intracellular parasite, starting with the oocytes, soil form, and especially in young cat as the host for the disease, and can survive for 1 year. Trophozoite, which is the active infection form and can go for lymph node and blood, and then can separate it to the different organ, including the eye. The tissue cyst, which is latent form, which can be dormant for a long time and then reactivated. The natural host is the cat, and the human is the intermediate host. We have two forms, congenital and acquired, and the acquired form is caused by ingestion of oocyte or tissue cyst in the previously unexposed host. Cyst found in undercooked meat, poorly cleaned vegetables, and the contaminated soil waters. It is transmitted from fecal oral contamination, and mother are at the risk to translate vertically the disease to her mother. This is the
Dr.
clinical
Hassan,
feature.
I'm sorry, we're running out of time. Would you be kind to maybe just sum up for the most important point in toxoplasma diagnosis?
Okay, Toxoplasma is
so
usually having a necrotizing retinitis adjacent to large old scars, as we see in this picture, and sometimes might having, great white punctate lesions in outer retinal layer, as you see in these cases, and might having, headlights in the fog, as we see in this picture, and ring of hyperfluorescence in these cases. Other form could be having retinitis when adjacent to the optic nerve and associated with vasculitis with scarly arteriolysis. Ophthalmic finding usually having massive retinal necrosis, especially in immunocompromised patient, and having previous chororetinal scars. This is the how-to diagnosis, usually in the clinical picture, supported by surgical tests, and PCR is the most important test can be used. CT scan could be used, especially in congenital, to rule out calcified CNS. Treatment usually for a small active peripheral lesion, observation and treatment has not been shown to be hasten resolution. While in case of macular involvement or significant vitreous, we can use pyrimethamine, sulfadoxine, treated for 3 to 4 weeks, and so on. Alternative courses could be used in these cases. Other cause of posterior uveitis as infectious, we have tuberculosis, and it's a big masquerade, and usually, especially in our area, is prevalent, and most of them are latent. It could be having posterior uveitis, which is most common, and multifocal choroiditis as miliary TBs. Tuberculoma, especially in immunocompromised patient, and retinal vasculitis panniculus. Choroidal granuloma could be having in such patient or in multifocal choroiditis. And, the surveillance like tuberculosis related. Diagnosis based on the presumptive in absence of pulmonary or systemic disease. Tuberculosis is one of the most important, and we have to be careful how to read it. Chest X-ray most of the time is normal. Acid fast bacilli culture are more sensitive, but it's very difficult to do it. Treatment usually with 4 medication, isoniazid, ethambutol, rifampicin, and pyrazinamide, at least for 9 months after primary or 4 medication of that. And this could be added by systemic steroid. Syphilis is another entity and need to be introduced in any cases, and there is a lot of form, and the disease could be confirmed by the lab tests, including RBR and VDRL.
So Didi, I think sorry, if you can summarize, thank you.
Thank you for your, and this is just to remind you by differential diagnosis of posterior uveitis infectious cause. Thank you, and I'm sorry for that. But
no, I'm sorry. I think, as we say, you had the short straw because this is the bigger topic. So I apologize for the time.
Thank you to be patient with me, and thank you for the attention.
Thank you so much. We'll move to Professor Pavizio from MUFAS and the Eye Institute in London. And Professor Pavizio, thank you so much. And he's speaking about the management of non-infectious posterior uveitis. Thank you, Professor Pavizio.
Thank you very much, Ahmed. It's a pleasure to be here with all of you. Let me just make sure I can share my presentation here with you now. So the intention here is to try to cover also in a very short time a very large topic. So I'll do my best here to achieve this objective. Challenging situations in ophthalmology are many, but I think intraocular inflammation is clearly one of our major challenges, and it's difficulties in making the diagnosis, difficulties in terms of management because of the limited options we have, and the potential for significant visual loss. I think our main objectives in managing these patients is to identify the cause, control the active process, prevent recurrences because they can lead to cumulative effect of damage, prevent the loss of visual function, not only visual acuity, but loss of peripheral vision, prevent and treat the complications which result from the inflammation or sometimes from the treatment, and avoid collateral damage as much as we can. There are several factors that play a role in our decisions to treat the patients, the location and severity, and the duration of the inflammation. We have to evaluate if vision is reversible or not, what is being lost, if disease is unilateral, bilateral, and if there's something going on systemically with the patient. Never forgetting this is overall health of the patient, potential interaction with other drugs the patient may be taking, and other comorbidities which may be interfering. And don't forget a very important point is compliance from the patient. So when you treat patients, we have local and systemic options. Topical therapy, very useful. We heard it talk about anterioveitis. This is where topical therapy is really the key. But of course, anything happening posteriorly will require the use of other modalities, including the periocular injections or intravitreal injections. And beyond that, we go for systemic therapy with our first line being steroids, and then utilizing immunosuppressants and more recently biologics. The local therapy is very useful if disease is only one eye or is asymmetric, if the eye is the only reason for treating the patient, so there's no underlying systemic problem for which treatment is required, if there's a contraindication or intolerance to systemic therapy. And we know in some diseases, the local therapy can be a good alternative because of the nature of the problem that we see. In terms of the administration, the periocular injections could be subconjunctival and subtenons, and then the orbital floor. Subconjunctival is very frequently used for anterior disease more than posterior disease, but subtenons is the one that we have over the years used more extensively. But recent studies have shown that they are inferior to the next alternative, which would be the intraocular injections that we have also been using for several years now. The slow-release devices have been around for some time. Retisert, the longest existing one, but not really available in Europe, very, very easily available in the US. But the other options, also Ozurdex and Iluvien, are currently approved for use in uveitis. This is just to show here the periocular injection, the fact that you put a steroid in the orbit, either an orbital floor or with subtenons, and that drug still has to get into the eye. So you still have to overcome the barrier of the sclera. When we put injection into the eye, you bypass even that last barrier, and we started with Kenalog, then we moved on to Triessence, a licensed indication for this use, and we can see the effect is very dramatic in reducing macular edema in a very short time. This study, the POINT trial, which was looking at the comparison of the periocular injection with the intravitreal triamcinolone and the dexamethasone implant, showed very clearly that the implant and the intravitreal triamcinolone are very much superior in obtaining resolution of the process in comparing to the periocular injection. Drug delivery systems came about to overcome the need to be repeating procedures all the time. We are very familiar with the fact that the procedure can work, but needs to be repeated time and time again. So if you can use a system that will deliver on a sustained form the treatment to the eye, with the advantage of trying to prevent recurrences, then you are in a better situation than allowing recurrences to occur and then having to treat them. The first one I mentioned before, the Retisert, was supposed to last for about 30 months, releasing 0.3 to 0.4 micrograms a day of the drug. It was inserted via pars plana incision and suture to the sclera. The time to recurrence was significantly superior in the group receiving the implant comparing to standard of care, and that was one of the main reasons why it got approved, but it didn't come without problems, especially pressure-related problems with a large number of patients requiring surgical intervention. So it really lowered the frequency of the disease, the recurrence of the disease. It stabilized and improved vision, but was associated with significant side effects. The Ozurdex, also familiar to most of you, lots of indications, diabetic macular edema, vein occlusion-related edema, and also uveitis. And the study showed very well, the primary outcome measure was vitreous haze, And it showed that the two concentrations of the dexamethasone implant were superior to placebo in achieving that control and also in improving visual acuity. It didn't come with a lot of side effects in the study because the study was very short, about 6 months only. So it was very effective in controlling, achieving the outcome, and was licensed for the use in uveitis because of these results. Iluvien has been more recently approved as well, is the fluocinolone acetonide implant, which will release the drug at a steady state of about 0.2 micrograms a day after it's being implanted into the vitreous cavity. It is not biodegradable. And we can see here the results showing that at 6 months, which is the primary endpoint, you have only a recurrence of 27.6% of the patients with the implant, comparing to 90% of the placebo group, the sham injection group. When you look at the end of the trial, 36 months, you still had about 34% of the patients not having recurrence. And those who recurred had only one recurrence in another 35%. So 70% had either no recurrence or one recurrence, comparing to the sham group that recurred pretty much within the first 6 months, most of the patients. It showed here that the duration of the effect, time to first recurrence, was significantly superior, with 657 days for the implant against 70 days for the sham group. Importantly, in terms of pressure problems, it was not associated significantly with problems with pressure, which is a very important point in this case. So very effective in maintaining control of the disease, in preventing the first recurrence, in reducing the need of other medications, and improvement of vision. Don't forget, VEGF can be also a target for treatment because it's present, especially in the presence of macular edema, and the reports indicating their benefit. But again, the problem is needing to be repeating procedure time and time again. In the pipeline, we're waiting to see if our suprachoroidal injection will allow us to control the patients very well. This triamcinolone injection is being recently licensed by the FDA, and we're hoping to be able to use it in the near future. Systemic therapy, always remember, first line of therapy, oral steroids, could be systemic in a different way, intramuscular or in the intravenous, but it is steroids will be your first line. And then usually, if you need to associate another medication, is an antimetabolite, and then we tend to go for the T-cell modulators. I left a gap there on purpose because this ladder has been changing, and we're more and more likely now to use biologics or interferon immediately after failure of the antimetabolite. But not forgetting that the T-cell modulators can be helpful. In terms of the alkylating agents, very powerful, but not frequently used. This is the major problem with steroids, long-term use, is that they are used usually too little for too long. So that's why the patients accumulate side effects without the real benefit of the treatment. So what we do in terms of immunosuppressive therapy, they're usually considered a second-line therapy because they're introduced when there's lack of disease control with steroids. So you need a large dose of steroids. So when patients are relapsing in the process of tapering the steroids, and you need associated another mechanism to try to achieve that control. These are the drugs most frequently used, especially the antimetabolites, but remember, they are limited many times by the significant side effect profiles they have, and I recommend always the help of a physician if you're not familiar with these drugs. This is just to show you that you should not combine mechanisms which are the same. You combine drugs with different mechanisms of action, so an antimetabolite, a calcitonin inhibitor, and then, of course, you jump for the biologics if they are not working well. Important to stress here, there's limited data from randomized clinical trials regarding the effectiveness of these strategies. Biologics, to end the talk, they've been introduced as recombinant antibodies that will target particular cytokines or the cell surface receptors. So they have been gaining favor because of the more target approach. There's a lot of evidence coming from systemic diseases, and we're building our own evidence on the eye side and uveitis, and clearly the visual trials were pivotal in allowing approval of adalimumab for the management of uveitis. Just to show you here the ones more frequently used, reminding you that etanercept is very good for rheumatologists and not a good option for us in uveitis. You should use predominantly adalimumab, or if necessary, infliximab, which now also exists as a subcutaneous injection. So it's no longer only limited to an infusion. So the more we know about the cells and the more we know about the signals which are involved in how the cells communicate, the better we are at understanding our possible points of intervention. And this is just to give you a glimpse of all the alternatives available, an area that is exploding in terms of more and more information and more options. And we hope to find, of course, in an area where we have limitations, we want to get more. So interleukin-6 blockade is being really well explored. Is it the next option when adalimumab fails? fails, and we have rituximab and potentially the direct effect of interference. Don't forget quality of life. Patients love not to take tablets. They want to feel well without systemic side effects, with less visits to the hospital, and no need for regular blood tests. So in conclusion, it's a balanced decision to take into account the diagnosis, anatomical location, bilateral and lateral disease. Don't forget the general health of the patient, the use of other medications, and the quality of life. Keep in mind that sometimes combining local and systemic therapy may be the best way of reducing the burden and giving the patients the best outcome. Thank you very much.
Thank you so much, Dr. Pavizio. Very well delivered talk. Okay, well, again, for the sake of time, we'll have to move to Professor Vishali Gupta. Professor Gupta is speaking to us about masquerade syndromes, and Professor Gupta is from Chandigarh, India. Professor Gupta, please.
Thank you. Thank you once again for the opportunity, and let me one second. Okay, perfect. For the next 10 minutes or maybe less, I'm just going to talk about masquerading malignancies. And I'm going to make it simple because I believe it's an instruction course. So though there are very clear-cut signs that we do have, and we have all been taught about intraocular malignancies, infections, non-infection, but the real world is kind of very different, and all of us who practice uveitis do at times tend to confuse infections as malignancies and vice versa. So what do we need? I'm going to show you very simple case examples from my clinic, not anybody else's mistake, and to show what all we missed. Now, this is a 49-year-old lady, which we saw a very long time ago, many years ago, and she comes that there is decreased vision in the right eye for 4 days and floaters. So she had this sudden onset. We did see vitritis. So you can see the year was 2009, and I was student at that time. So we did fluorescein angiography, and not student, but I was junior faculty. So we did the fluorescein angiography and did see vasculitis. And as you know, tested for TB. TB came positive, excitedly started on ATT and steroids and everything. The inflammation was not going away. And even after 8 weeks, though media did clear, the inflammation did not go away. At that time, I was foolish and I started azathioprine. But if I look back today and I notice these spots, I would not miss it for anything, because these are the spots which were actually suggestive of the possibility of lymphoma. So even if the initial test was positive, but if the patient was not responding the way she should have, I should have taken charge of few things. But I delayed it further, and over the next 15 months, she developed what is very classically the subretinal deposits of lymphoma. You can see the RPE elevated, leopard skin pattern, and of course, it was lymphoma. Did the vitrectomy, and not a surprise that it was all the features which were suggestive of lymphoma, treated with methotrexate. In 2009, we were not using rituximab. Did, MRI, which was normal, but by the time I was smarter, and we kept on repeating MRI year after years, and she actually, in our scenario, since she did not have any lesion in the brain, though she was advised prophylactic chemo to the brain, patient had refused. So we were keeping her under very close observation, and after 5 years, actually, she developed these lesions in the brain. And subsequently, she was treated for the same. And this is 6 years later. You can see the lesion is now evolved, and, she responded. So the outcome, which I would like to tell my young colleagues, that the first presentation here was vitritis and retinal vasculitis. Now, retinal vasculitis is not very common presentation of lymphoma. So, we have published this case actually in Lancet. So it's not a very common this thing of lymphoma. So even if I missed, but the way vasculitis should have responded to anti-TB, if it was not responded, that was the time to take charge and re-investigate. Positive test for TB, of course, misled towards the diagnosis of tubercular retinal vasculitis, but still one needs to have very high index of suspicion and revise your diagnosis if things are not going the way you expect them to go. And this is my second situation where I thought it was a malignancy, but it turned out to be an infection. Now, this is a very young girl, a 19-year-old girl. The vision is 20/100. And she was actually being treated on antifungal somewhere. And there was absolutely no inflammation, beautiful quiet eye, and we had this yellowish mass. So my first impression was, is it metastasis or something going on which is producing this? Fluorescein showed mixed with the late phase leak, nothing great, and the OCT ultrasound. Ultrasound shows this kind of a lesion, which was not really only confined to the choroid, but was involving the overlying retina as well. We did every possible test. The test for TB were, of course, negative, but she did have bilateral axillary lymph nodes, which were palpable, but they were mobile. They were not really hard or matted, one would expect in this. So we did the PET scan, and PET scan showed that, there was a huge uptake everywhere in the omentum, in the ovaries, in the peritoneum. So the primary thing was that there is something happening in the ovarian. So I thought, okay, it's ovarian with metastasis, and that's what I'm seeing. And strangely, the biomarker CA-125 was really elevated 10 times, and so was LDH. So a gynec consult was sought, and she underwent FNEC guided biopsy, and behold, the biopsy shows caseation necrosis, aggregates of lymphocytes, plasma cells, epithelioid cell granuloma, PCR positive for tuberculosis. So, it was a very good news for her. So she was treated for tuberculosis, and this is how she responds, with the improvement in the vision. So not only that, you can see this is the PET scan before and this is after treatment. So it was basically the tuberculosis of the peritoneum and all the pouches, more of a disseminated thing. So the lessons that I learned from this case, young patient with large choroidal tuberculoma, and she actually had a peritoneal tuberculosis, which was vast. The diagnosis of pelvic peritoneal tuberculosis is difficult, but because of the non-specific clinical lab radiologic findings. I'm not going to talk of other things, but sometimes even the biomarkers can be confusing, because this case taught me that CA-125 can actually be elevated in tuberculosis and not really a great marker for ovarian cancer. And of course, PCR. So my advice to my younger colleagues is that if you are seeing any rarer cases which do not have a usual presentation, malignancy infections can masquerade each other. So don't hesitate to go for more invasive investigations, including PET scan, including biopsies, vitreous tap, because you don't want to waste time on trying one therapy after the other. So these days I have a very low threshold, and whenever I'm confused, I just do diagnostic vitrectomy and sort it out. But for instruction course, I have picked up the cases where I kind of was confused, and I kept on thinking about ways other than diagnostic vitrectomy to make the diagnosis. Thank you very much once again.
Thank you, Dr. Gupta. This is fantastic. It's a fantastic case. Can I ask you, Ree, as a message for the first case, would you think that, I mean, there are some thoughts that, okay, if you have a non-infectious uveitis or a presumed non-infectious uveitis, you give them systemic steroids and they are not responding, then go on to a second-line immunosuppressive. My thinking is that most of the non-infectious uveitis should respond well to steroids, but the problem is what Dr. Pavizio summarized is like when you taper down, they will flare up or will they get side effect problems or need long-term control. So my question is, do you think like a second-line immunosuppressive drug can have more anti-inflammatory effect than steroids or no?
It does have, but when we have to start immunosuppression, we have to be very sure that we are seeing something which is autoimmune. Like in this patient, we did start as a thiopurine, but it was a masquerade, you know. So I think if it's a 59-year-old woman who's developing vitritis for the first time and some vasculitis, which was not predominantly vasculitis, it was predominantly vitritis with vasculitis. And I was not seeing any synechiae or any anterior segment inflammation. And these days, you know, even the character of the cells in the vitreous, if they are larger, if they are forming clumps. So I think before believing that they are autoimmune, it's better to rule out masquerades, especially in this age group.
I think just one comment here, if I may.
Yes.
I think the point that is very important is before you start any significant immunosuppression, you do all your best to exclude a masquerade or an infection. Basically, it is your first basic step in the whole process because the treatment is very different. But sometimes, in spite of all that, you're treating a patient and the patient not responding in the way you're expecting the patient to respond. So when you see something that you're expecting to have a positive effect of your treatment, that's not happening. It means you really have to stop and think again, because your initial investigations kind of gave you some reassurance that it was okay to go ahead and immunosuppress, but the clinical behavior is kind of telling you something different. So you have to stop, pause, and as Vishal is saying many times, you have to go more aggressively, invasively to be able to confirm the diagnosis, because surprises do happen. So the clinical behavior is really a very important signal that if you are winning the battle, if you're doing the right thing, you should be seeing improvement. Sometimes that doesn't happen.
Thank you so much, Dr. Pavizio.
You don't have any ego in uveitis and you don't fall in love with the diagnosis you make because it keeps changing every time. So
I think we can all summarize was anything better than that, really. So if you're not having good response, particularly if you're not seeing the response you're expecting with systemic steroids, then stop and think. Well, thank you so much. I would like to thank all the panel, Professor Gupta and Professor Pavizio and Dr. Eldibi and Dr. Dina Baddar. And thank you so much all.
Thank you.
thank you
very much.
Thank you.
Bye.